All right. Hello, everyone. Welcome to another Wednesday VMR. I am I'm so excited because I had the privilege of co-discussing with Sharmin today, and we get to learn from Rahul's great case. And it's so fun to see a lot of you guys here because it's on the later side. I think this is one of the latest VMRs that at least I've tuned into. So it's fun to know that, no matter what time, what place, there will always be CP solvers, community members here to learn.
It's always a good
Yes,
time to nerd about medicine, you know?
exactly.
Always.
Andrew is sleeping on the couch with his dog. That's great. Charmene, how are you doing?
I'm doing good. Super excited for today's case. And it's always such a pleasure discussing with you and learning from you, Maddie. So I'm super pumped. Rahul, whenever you're ready, and if you're ready to get the board up, then we can get started. Shout
Absolutely.
out to Bayan and Johan for doing scribing and teaching points. Really appreciate you all. All right, Rahul, the mic is yours.
All right. The first chief complaint is complaining of right breast pain. And let me stop here.
All right. And Rahul, just to make sure I heard, is this the breast? Is
Yes.
that right? Okay. Okay. Just wanted to make sure I heard that right. Um, all right. So with right breast pain, um, the breast is located in the chest. So I think I would actually translate this to chest pain, and want to make sure we rule out kind of all of the do not miss causes in chest pain. Um, and, of course, we've gone through kind of the 4+2+2 mnemonic for the do not miss causes of chest pain, including cardiac causes, pulmonary causes, esophageal causes. So kind of moving through those, we can kind of pull up that schema when we get to it, but really I want to make sure this is not an acute coronary syndrome, getting an EKG, troponin, considering in the back of my mind, is there, do we need to be concerned about pneumothorax, pulmonary embolism? So I think what I'm doing with right breast pain is I'm making sure that this is, you know, do we need to consider all of the scary considerations we usually have when someone comes in with chest pain? But if someone is actually using that word, my right breast hurts, then that makes me more concerned of, well, like the structures in the breast. So could there be kind of a skin and soft tissue infection within the right breast? Has the patient recently had a surgery to the right breast, and could there be complications of that? I remember in medical school seeing some really horrible infections that you can get from the breast after some surgeries there. So um, to summarize, right breast pain, because the breast is located in the chest, I want to think broadly about scary causes of chest pain. But also, if someone is using the word breast, I want to make sure we kind of focus on the structures there. Could there be some type of skin and soft tissue infection? Have there been any recent surgeries? And that's really what I would be focusing on. Sorry, I think the VA is cleaning their floors right now. I'm sorry if it's loud. Um, I think what I would do is I would ask the person, I would probably visualize the right breast just to make sure, is there some type of obvious infection there before taking next steps. But pertinent parts of the history is, how long has this been going on? Have there been any type of surgeries or injections or interventions to that right breast? And that's where I would start. Charmaine, what are you thinking?
Oh, I just love listening to you discuss Maddie. That was beauty. I love that it's easy to just like go and focus on the right breast because that's where the complaint is, but taking a step back and translating it into the chest wall to make sure you're not missing any of the no misdiagnoses, that you're right. At the heart of it, it will be like cardiovascular, mostly, plus the two and the esophageal, which hopefully less likely here, or like the two pulmonary causes. I absolutely love that. I totally agree with you in terms of like kind of the right breast portion of it. And the only thing that I would add is like, I think like the age, as you mentioned, is going to be really informative. This is like a postmenopausal woman. Is this a person who recently had like delivered a child? Oftentimes, like people at higher risk of like ducts getting obstructed, causing like mastitis of some sort. In terms of like the other diagnoses that come to mind is that some of like inflammatory breast cancers, I believe, can be quite painful rather than like the breast cancer itself is oftentimes not painful. Um, and the other thing that I always like want to first think about is like, with any causes, like not forgetting about skin, any like skin changes, as you mentioned, like cellulitis, a zoster, all of those things that can be painful. And then muscles involvement, ducts involvement would be very informative. But I think like, as you said, I really love that you thought about like the post-op complications as well, like if any procedures has been done. Yeah, so like the past history and also like the age of the patient would be really informative to kind of make a little bit more progress. Cool, Rahul, back to you.
I loved your discussion, like it initially with the chest pain evaluation and then focusing on the local breast pathology. And let me share the second aliquot. So she's a 55-year-old postmenopausal female, and she's presenting with 2 days of right breast pain. Initially, she felt the area has been itchy and associated with some burning pain, particularly at the level of nipple, and she also noticed some clear discharge on her clothing. No recent trauma to the area, currently not sexually active with a partner, no recent breastfeeding, no previous history of this happening before, and she has been using some lotion to that area, but it did not help her. And rest of the review systems were negative. And coming to the past medical history, she had a history of rhinoids, dry eye, hypertension, and type 2 diabetes, complicated by retinopathy, neuropathy, lichen sclerosis, and GERD. And the med she's taking was and semaglutide, atorvastatin, cyclosporin, lisinopril, esomeprazole, dapagliflozin, metformin, pioglitazone. Family history is not significant. Social history, she lives alone and she works at restaurant. And social history, I mean, drug history, no tobacco, no alcohol or drug use. So this is the end of my second aliquot.
All right. Thank you so much, Rahul. And again, I'm sorry for the loud noise with the, all right. So this is very interesting. So what we learned from you, Rahul, is that this has been going on for 2 days. It started off with itchy, burning nature, and then we're also associated with some clear discharge, no trauma or breastfeeding. So, I think it'd be helpful, kind of how Sharmin described in this last aliquot, to take an anatomic approach. So is this related to pathology of the skin and soft tissue in the breast? Is it related to the ducts within the breast? Has there been some compromise to the vasculature, or to kind of, the breast is a very fatty tissue? Is there some issue with kind of the fat in the breast? So, or kind of also related to the anatomical structure, could there be an issue with like the nerves in the breast? And I think it'll be important here, the patient is using the word breast pain, but similar to how in the first aliquot, I took a step back and was thinking, oh, is this chest pain? I think we need to make sure we don't just narrow in on the breast. So for example, when Rahul used the word like the pain was burning in nature, what made me think about it is I'm going to be very curious to visualize the area, see if there's some type of rash. Zoster just kind of came to mind as a type of rash that can be present in that area, kind of in that dermatomal distribution. So perhaps, I think I just want to make sure we're not only focused on the breast when it could be not localized to that structure. So I think what's really going to be helpful here is the physical exam to see if there are surrounding skin changes, to see if we're able to see kind of discharge. I imagine that's like the clear discharges from the nipple, but to see if she was reporting it was clear, could it be bloody? Is there any kind of pus or purulence there? And yeah, I think Yeah, I think what's still on my differential is like skin and soft tissue infection, but still some type of pathology within the breast, whether a benign or malignant lesion. And I think I'm still keeping myself open to the possibility that this is not just localized to the breast, and maybe is something deeper within the chest. So keeping that open. In terms of the past medical history and medications, nothing is standing out to me as things that may be completely related to the presentation, but I'll kind of keep the history of type 2 diabetes, hypertension in the back of my mind as maybe related in the future. Would be curious about her type 2 diabetes to see what the last A1C was, to know how well controlled that was. And I will pause there, but yeah, I think what will be most helpful is kind of the physical exam at this point. And I'm not entirely sure what to make of the clear discharge. Yeah, so maybe I'll pass that to you, Charmaine. I'm curious, like, what progress you're making from this, and if the clear discharge at all, like, helps in any way.
Brilliant discussion, Maddie. I totally agree with you. And, I practice at the VA. Majority of my patients are men, so I haven't thought about the breastfeeding in a long time. So this is why VMR is so great. And I really love like falling back on anatomy whenever you don't feel like you have a good enough schema. So like thinking about the skin, the fat, the muscles, the ducts, the nerves, and all that. It would never um, let you down. I think in terms of like the clear discharge is a little hard to. Well, I mean, I think if it was like a pus coming out, it would be helpful. Sometimes, like with postmenopausal women, like hormonal changes can has an effect, but it does make you worry that like whatever is going on may involve the ducts. And I think like as you get older, like I think cancer just rises in concern. Again, like pain would be a little odd unless like it's causing nerve involvement, vascular involvement, or just like is inflammatory in nature. The one thing in her past medical history that, in terms of other than the diabetes, like a couple of things to note about her diabetes, like she has a lot, we don't know the A1C, but sounds like she has complications of her diabetes, which makes me think it was probably not well controlled at some point. And the other thing you can also know is like the number of diabetes medication she's on. She's on at least 4 regimen. So that kind of tells you like, hopefully, that at some point she's had complications of it. So she's kind of at risk of like having infections and like being a little bit, compromised from her diabetes standpoint. The other thing that jumps out to me is like a lichen sclerosis. I assume it's like a genital involvement. There is like extragenital involvement of a lichen sclerosis that tends to be benign. However, it involves the skin, the patchiness of it. I don't know much more than it can involve other parts of the that it can be extravaginal, but that's something to also like keep in mind. But as you mentioned, like I think exam would be really helpful in like helping us like make a little bit more progress in in that. And yeah, I think I'll pause there. Any other thoughts, Maddie?
No, I love that, and I think yeah, I think adding on to kind of your discussion, I think some things I would be asking the patient is like, has she had a recent mammogram? Just to your point, if a 55-year-old woman, cancer is, always a thought that should probably cross our mind when someone has any type of concern related to the breast. So that is something I would be asking her about, and looking back through to see if we have any records of that. And trying to see kind of if there's anything that she thinks may have brought on, like, did she, I don't know, put some type of different lotion or anything, that like new clothing or weird thing that could cause like a contact dermatitis or some irritation there. I'd be really trying. It's interesting that it came on so acutely. Cancer doesn't come on in 2 days, but maybe it just like rose to the surface in these past 2 days. So I think I would really be trying to get at any triggers or worsening factors that that the patient's able to identify.
Beautiful. All right, Raul, back to you.
That was brilliant. I mean, I loved your discussion on the localized breast pathology. Let me share the A1C in the labs. And first of all, I would like to share the vitals. Coming to the vitals, the blood pressure is 110/60, and pulse rate of 50, and respiratory rate of 18, BMI of 27. Let me share the breast image first. If you're okay with that. Can you all see the image? Yeah.
Yep, we can see it.
Perfect.
Do you want us to stop here, Rahul, and kind of say what we're seeing?
Yeah. So I would love to hear your thoughts based on the gross findings, and let me share the findings on the physical exam in a more descriptive way.
Yeah, so I think, what I was really anticipating was, are there significant skin changes here? And I'm actually not seeing significant skin changes on the breast from this photo. Like looking at the nipple area, maybe there's some kind of some minor crusting from discharge that was reported, but I mean, it's actually a little bit unimpressive in terms of things that it doesn't look that abnormal to me. I was expecting it to be a little bit like more, so I was expecting it to jump out to me more. I think what I would do is I would do a breast exam to see if there is tenderness there, and I would kind of compare to both sides. I would do a breast exam to see if there's tenderness, to see if there's any lumps, to see if there's any kind of surrounding lymphadenopathy, especially in the axilla. But I think what stands out to me here is that the skin looks pretty normal. And there's not like significant purulence or bloody discharge at the moment. I'd also probably like try to express to see if there's any discharge that comes there as well.
Yeah.
Sharmin, what do you think?
Yeah, I totally agree. I think like thinking about like whether there was any overlying erythema, we don't really see that. I think comparison with is key to compare the right to the left breast. The nipple area skin looks like a little darker than the area around it. Whether that is like normal for her, abnormal, I have no idea. And I think that's the question that you would ask her, and then comparing to the other side. And I agree with you about the crusting and whether there is anything expressive. Then I would just like ask for like any change in coloration that she's noticed. But yeah, I totally agree with you. I also and like it's kind of amazing. Like I also like I thought it would be like a more impressive, but I think like the best way is to like compare it to the other side, and that will probably tell you if there's any changes. But I didn't see like any big inflammatory changes. And I think that makes me a little less concerned for a kind of inflammatory breast picture. But but yeah, unless like there's something brewing in the ducts that is causing some that is more like internal rather than external, that it hasn't risen to the surface as you've met, that is just causing some pain. But yeah, I think yeah, I'll be curious to see like what the palpation exam showed, and that kind of the comparison to the other side. Back to you.
Absolutely wonderful. And let me share the exam findings. Coming to the general exam, she is AO times 3, and hint exam is normal conjunctiva, no evidence of lymphadenopathy. Breast exam, bilateral breasts are without signs of any masses, and no axillary lymphadenopathy as Maddie was asking about. And right breast notable for any enlargement of nipple, and dried fine white scale and some discoloration with comparison to the left breast, and some discharge from nipple, and no warmth, erythema, or tenderness to palpation bilaterally. And cardiac exam, lung exam, abdomen, neuro, skin exam were perfectly within normal limits. Let me stop here.
Yeah, thank you, Rahul. Well, I feel a little bit relieved for this patient. I don't know if that's too early to say that, but I'm reassured there's no palpable masses or lymphadenopathy. It sounds like what's most pertinent is so just to clarify real quick, the white scales, is that kind of like the dry discharge, or is that something else that you were describing?
I think it was described that dries, I mean, from the discharge itself.
Okay,
From the,
got it. Yeah. So it's really interesting. So it seems like, the problem we're narrowing in on is like unilateral right breast pain with clear discharge without other significant overlying skin changes and no palpable masses and lymphadenopathy. So this seems like a pretty localized process to that right breast. And I'm thinking, at the beginning we were talking about, do we need to be thinking of like chest pain and disease in the larger thorax, but this does seem pretty localized just to that right breast. So now, with the discharge, we were kind of talking about an anatomical approach, skin and soft tissue, nerves, vessels, fat, ducts. And with this clear discharge, I think I'm kind of narrowing in on the ducts, like why is there some excess discharge there? And um I'm wondering if like a mastitis could cause kind of like clear white discharge. So that's kind of like the biggest thing that comes to my mind. I'm trying to think of like what I would do next. And I think I'm wondering, I'm trying to put myself in real life, like would I get basic labs in this person? I'm not 100% sure I would, to be honest, if I saw this person in like an urgent care setting and she came in with just this discharge, but I think it could be helpful to get a CBC to check the white count. If this person had like significant leukocytosis, that would probably change my thinking. Um, I'm trying to think of like imaging you can get for the breast. Like, can you just start with maybe an ultrasound to see if there's any type of mass or, like abscess that we were not picking up on just from visual inspection. So I would probably start with some basic labs, at least a CBC to check for leukocytosis, and maybe start with an ultrasound of that area. But I think I'm narrowing in on this is like a local process at the right breast with that discharge, maybe an issue with the ducts, like a mastitis. Charmaine, what are you thinking?
Yeah, I agree with you, and I'm a little puzzled because I think the question that I have would be like, is the right enlarged nipple new, or is that just an asymmetry she's always had? Because it takes time for a structure to get enlarged, right? So then the question is like, is there something pushing on it? Is there an abscess hiding? Is there a mass that is hiding behind it? Because I think the area was also firm. There are like bunch of I think like adenomas or like benign conditions that can cause asymmetry and enlargement of the nipple. But I think like Paget disease can involve the nipple, can kind of present like this, like more invasive ductal stuff that maybe she just has noticed it. But yeah, I'm trying to like I'm trying to make sense of the discordance of the 2 days of symptoms versus an enlarged structure, whether they go together or they're like there's two separate processes that is going on, but it does I feel like an enlargement of a structure leads me to think that this is a more of a subacute issue that has been going on, and did it just come to surface because patient recognized it because of the pain and discharge. And I think in terms of like your point about like whether you would get labs or not, it sounds like she's kind of afebrile. Yeah, I think it's hard not to think of abscess. So I would probably get your CBC to see if there is a systemic infection going on. And in case you need to image later, not a bad idea to just get a creatinine just to make sure. And ultrasound is like where I would start to make sure that there is like no abscesses or something like that. And whether that is revealing or unrevealing, then like a mammography may be indicated if you're more worried about like something invasive and less the mass-like. The firmness of it has me a little bit worried that maybe right below the surface of the nipples, maybe like an invasive ductal situation going on. Whatever is happening, we know it's involves the ducts because she has discharge, whether that is an infection or a malignancy, I think, or some like a patch of disease, then I think that is like kind of the three big categories I'm thinking about. Any other thoughts, Maddie?
No, I just think that was a great pickup about the enlarged nipple. Just kind of looking back on my thinking, I just did not like find significance in that, but I think that's a really good point and mentions, as you said, that the time course in this is likely longer than 2 days because, you know, a nipple wouldn't enlarge that quickly.
Mhm.
Yeah, that's a great point.
Yeah, and kudos to whoever did this exam to look for axillary lymphadenopathy because that's where you would worry. So that's a great whoever did this exam. Kudos.
And
All
then
right.
Rahul, just to make sure so just for the exam, so it sounds like on the right breast, it was like the right nipple was more enlarged than the left side, and then there was tenderness around the nipple, or was it the whole breast was tender?
I mean, when compared to the based on the information, based on the history, the right breast was comparatively enlarged to the left, and it was not like a tender. It was a kind of pain around the discharge area around the nipple, but otherwise, rest of the breast parenchymal tissue was completely fine. The problem is going on around the nipple areolar complex, I would say.
Okay,
Yeah, yeah.
thank you for clarifying that.
You're welcome. And do you want to give them more information, labs and imaging?
That would be great. Thank you.
Perfect. And coming to the labs, a sodium of 138, potassium of 4.2, chloride of 109, bicarb of 23, Bu1 of 7, creatinine of zero point 0.7, glucose of 315, calcium of 9.3, alphos of 206, albumin of 3.6, total protein of 7.4, AST 42, ALT 63, TBL 0.2, and her A1C is 8.1. She's down from 9.7 from the last check. It was 6 months prior. And white count of 7.9 with a normal differential. Hemoglobin of 13.4, MCV of 77, platelet of 318. And we got the urine analysis. It showed 3 plus glucose, with the rest of the findings were normal. And SSA and SSB negative, the serology of Sjogren's, and ANA was positive, but unfortunately we don't have titers. And last mammogram was done in October of 2023. It showed BIRADS, I mean breast imaging radiology, the BIRADS category of 2, which suggests of benign findings. And this is the end of my fourth aliquot. Yeah. And we have 2 more aliquots for the final diagnosis. Let me stop here.
All right, thank you, Rahul. So just to kind of summarize what I heard you say, so it sounds like the basic metabolic panel was overall within normal limits, except for the glucose that was elevated in the 300s. For the liver panel, I heard an elevated ALK phos to in the 200s. The CBC, nothing quite stood out to me there. We have an elevated A1C that was 8 from 9.7, if I heard correctly. A UA with some glucose and a positive ANA. So I think what's standing out to me from these labs is basically kind of the significance of her diabetes, and that even with the several medications that she's on, not under optimal control. And so to me, how this could be related is that her immune system is compromised given her diabetes, and she could be at risk for more infections compared to someone who does not have this advanced diabetes. The ANA positivity I'm not making much of because I know that, what is it, like 1 in like 20% of the general population can have a positive ANA. So I'm really not putting any stock into that data point, and maybe we can reevaluate that later if it becomes relevant. But right now, I'm not really incorporating that into my thinking. And then the elevated alk phos. So I have like an association with my mind of the word Paget's disease and an elevated alk phos, but I am like completely forgetting that disease process. So I'll have to lean on Sharmin for that. Um, but I'm not sure how much progress these labs make for me in terms of getting to the bottom of why she has right breast pain. I think I would want to get an ultrasound to make sure we're not missing, as Charmaine said, like an abscess or other structure that's compressing on the ducts. But I'm overall not making too much progress with these labs. Charmaine, what are you making of this?
I totally agree with you. Turns out you were right about the labs. They were not that informative. In terms of like the elevated ACFOS, I think Paget disease of the bone can cause elevated ACFOS. In terms of like the Paget disease involving the skin, involving the breast, I do not think so. But if somebody knows in the chat, please let me know because that can totally be a gap in my knowledge. I do worry that if we say, I think a GGT would be helpful, but it does, given her age, a discharge, oftentimes like with bloody discharge, you worry more about malignancy, but I do worry about bony involvement here. So I would like get a GGT and try to figure out if that source of it is coming from like bone and if there's actually a cancer that has metastasized to the bone. So that is kind of the red flag for me and my no misdiagnosis with the elevated ALK-Phos. And I think you're um the layering of like her diabetes and like control infection I think is a really good one. We haven't really have any other evidence of it, but definitely a higher risk. So I think like getting the ultrasound and a mammography, and I think this is going to end up in getting a mammogram for her. Probably that's a good place to start. The question is like, oh, whether you want to evaluate the bone as well. But I think like depending on where your practice is setting up practicing, I think like first evaluating the breast makes sense to me. And the other thing that I was just thinking about, discharge, because we're like thinking more about like, oh, breast involvement. Thinking about like taking a step back and thinking about endocrine access, like a prolactin, like something that causing elevated prolactin that can cause nipple discharge. It would be odd that is unilateral. I would assume that it might have been bilateral, but that's another thing that just like came to my mind as I was like thinking a little bit more. But again, unilateral nature of it, it would be odd for it to be a more systemic endocrine process. So, yeah, I think like then, as you mentioned, localizing into the right breast, like getting an ultrasound or mammogram would be my next step. And I 100% agree with you, ANA. I'm like, what am I gonna do with an ANA? That is positive, unless like there comes a signal somewhere about like an autoimmune, then I would like I'm inclined to also ignore it for now. All right. Back to you, Rahul.
Loved your discussion, both of your discussion. And let me share the next telequad. And the patient was started on the topical steroid hydrocortisone, and she was referred to the dermatology. And she was seen by the dermatologist 3 weeks later. And the patient reported there's only mild improvement in the itching, but there is no significant resolution of symptoms. And by the time when the dermatologist saw the patient, the exam was quietly not changed much, and they performed punch biopsy. And the next aliquot reveals the diagnosis and subsequent histopathological findings. Let me stop you.
Rahul, such an interesting case. My gosh.
I do love dermatology and the fact that they biopsy everything. It does bring me joy that they just go for it, you know?
I know.
Oh, what do you
Well,
friend?
so okay, let's just summarize where we are. So 55-year-old woman history of poorly controlled diabetes, coming in with 2 days of right breast pain, found to have some clear discharge in large right nipple, and that's where we are, and like not improved with hydrocortisone cream. And so I think, just the fact that Rahul gave us the hint that she went to the dermatologist and got a punch biopsy, I'm wondering if when we were taking kind of the anatomical approach, we're still are thinking, because it's that there was, because of drainage, there was an issue kind of with the oh my gosh, I'm like losing the word, with the ducts in the breast. But now I'm kind of, given that a punch biopsy was helpful in the diagnosis, I'm wondering if there's a process localized to the skin, even though we didn't visually see that. And looking back at her past medical history of lichen sclerosis, I would definitely have to read more about how lichen sclerosis can affect the breast. I'm wondering if that's related. I'm just a gap in my knowledge if it affects the breast, but I'm overall really not sure here, and I'm excited to learn from Rahul. But yeah, I'll just pause there. Sharmin, what do you think?
Yeah, I agree with you. For her, I hope it's a benign, like lichen sclerosis of the breast can happen. It can affect any part of the skin. Not that I've ever seen it, but I think it can do it. And I think that the one that I wouldn't want to miss is like Paget disease. Often involves the discoloration, like, with the fine scales, makes me think like maybe Paget's. Like I favor a little bit of like a Paget or like a skin ideology. And I think like the worrisome diagnosis would be an underlying malignancy, especially with that alkalis elevation. Hopefully they're just unrelated to each other. But I do worry about like maybe a Paget situation, but I'm not 100% sure. Yeah, Rahul, take it away, my friend. Tell us, teach us.
Fantastic decision. And let me share the biopsy findings. It showed subacute spongiatic dermatitis with dermal eosinophils and negative PAS staining for fungal elements. So the final diagnosis was nipple dermatitis. It could be any variant of atopic dermatitis. And based on the findings, when she was on the clinic, they thought it could be more of eczema or contact dermatitis. And also given the history of vulvar lichen sclerosis, and they're wondering is it could be any extra genital manifestation of the vulvar lichen sclerosis. And given the hyperacute manifestation, they are thinking less likely of Paget's disease, and she was started on triamcinolone 0.1 percentage for a suspected nipple dermatitis before the biopsy results came back, and it was high potency when compared with the hydrocortisone cream, and they saw complete resolution with this. And the final diagnosis was an atopic dermatitis, and she was planned to get this year. Yeah, so that was the final diagnosis.
Rahul, what a fascinating case. And I really appreciate you bringing this case, one, because I think we talk about chest pain, abdominal pain a lot on VMR. I don't think like right breast pain is a common chief concern we get to talk about. So I really appreciate you bringing this, because it's I feel like I don't think about my schema for breast pain, but something that I'll think about after this. So I really appreciate you kind of stretching the CP community and stretching me in this way. And I'm curious, like, if you were able to, I don't know, sure if you saw this patient yourself, but like, how did she do with this cream, and like, did she improve?
I mean, first of all, I did not saw this patient on my own, and this was Austin's patient. And Austin shared this case with me, and I loved all the how the patient has progressed. And but based on the triamcinolone 0.1 percentage cream, they saw the complete resolution of the all the lesions and itching and burning pain. Yeah, that was the final outcome for this patient.
And then one clarifying question. So was it atopic dermatitis, contact dermatitis? Do we
I
know?
think it was a tricky question. They thought it could be of either of that. It could be atopic dermatitis, or it could be any irritant contact dermatitis. That was unclear, but maybe they
Got
also
it.
thought extragenital manifestation of vulvar, I mean, lichen sclerosis.
Like, got it. So a little bit unclear, but could be a few of those. Wow.
Like,
Rahul,
fortunately,
really appreciate you presenting this. Go ahead, sorry.
I mean, fortunately, patient, it was very benign, and patient fortunately responded to the topical high dose steroid cream. Yeah.
Thank you so much, Rahul. Yeah, and it's fun. I'm not sure if this person presented to an emergency department, but this definitely could be kind of like a primary care case, and it's always great to practice that type of reasoning as well. So thank you so much for preparing this. Sharmin, what do you think? What are your reflections?
Oh, this is an incredible case. I'm glad it turned out to be a skin condition, but I do think like you just have to entertain malignancy. And I think still I would encourage this patient to get a repeat mammography. Um, and mostly because like the discharge bothers me.
Yeah.
I would not anticipate discharge with just a skin condition. So that is a part that I like, and I think like that's something that to just keep monitoring. If like the skin resolves with she's still having the discharge, I mean the fact that it's clear is a little bit reassuring, but
Yeah.
um I'm grateful that it's like a benign skin condition, and I would still encourage this lady to get a mammography just to be on the safe side.
Yeah, I agree. I agree.
Yeah, but yeah, I mean, of whether I think the hard thing about like it's like atopic dermatitis, lichen sclerosis. Um, I don't think like from a treatment perspective it makes that big of a difference.
Hmm.
Eczema would have been like if she hasn't had any other history of eczema, it would. It's also like odd why now. So I think if it's like a lichen sclerosis, you're like, oh, she has a history of it now, she's having extra vaginal. If it's like eczema, then it's like interesting, like why now, at the age of like 55? So like contact dermatitis or like extra vaginal lichen sclerosis makes sense to me. I'm grateful for dermatologists. Derm is not my strong suit, and I'm grateful for them to help us out.
Me
Any other?
too.
Yeah, absolutely. All right. Thank you so much, Rahul, for presenting, and shout out to Austin for always like bringing so many great cases to VMR. All right, Johan, do you want to take it away?
Yes, of course. Well, first, thank you for this amazing discussion, and thank you, Raul, for presenting a really interesting case. So I'll quickly go over the teaching points. So we started with an approach to breast pain. So as Maddie said, breast pain first start rule out chest pain, and we think about the 4+2+2, so cardiac, pulmonary, and esophageal, and we go through the general workup, EKG, tropes, um, um, radio, etc. And then we think about a general anatomic approach for the breast pain itself. So first the skin, think about SCC, BCC, or melanoma. The duct, think about intraductal papilloma, Paget disease, or for the parenchyma, think about fat necrosis and abscess. And then we went over the past medical history and the HPI itself. So if the patient has a history of surgery or injection, think about soft tissue infection. Is the patient is postmenopausal like our patient? Think about mastitis, think about ductal obstruction or mastitis or malignancy as well, um, regarding of the age. If there is a burning pain, rule out other non-breast related causes like zona, for example. If there is a discharge, is it bloody? Is it purulent? And compared to the other side as well, to the other breast. And here our patient has a history of lichen sclerosis. So maybe the patient has extravaginal involvement, like skin involvement, skin affection of the lichen sclerosis. And for the physical exam, we check for inflammatory changes on the breast and we compare to the other side as well. And in our patient, we had an enlarged nipple, and it point, as Charmin said, to a subacute process. So think about doing an ultrasound or a mammography as the patient had to rule out abscess or malignant causes. And now for a final diagnosis, nipple atopic dermatitis, while the manifestation are pruritus, erythema, crusting, lichenified skin, and other atopic dermatitis on the skin overall. It's treated with topical steroid and emollients. And for the DDX, we have packet disease of the breast, allergic contact dermatitis, and psoriasis. So thank you, everyone.
Thank you so much, Johan. You captured absolutely everything. And I love how you organized it. All right, Rahul.
Brilliant.
Nice seeing you on, Rahul. Thank you so much for presenting the case. Sharmin, so fun co-discussing with you.
Always, friend. Always. Thanks all for hanging with us. We'll see you next time. Bye.
Bye.